Good afternoon. Welcome to APAICS's inaugural Health Summit. I'm Madeline Milka, President and CEO of APAICS, the Asian Pacific American Institute for Congressional Studies. Thank you for joining us today as we dive into a panel discussion on the next phase of COVID and how the Asian American, Native Hawaiian, and Pacific Islander community recovers from this pandemic. We appreciate all of the audience's terrific questions today and engagement, so please continue to put your questions in the chat in Facebook and YouTube. I'd like to thank our event partner, AmerisourceBergen, for supporting this panel. Before we begin, it is my honor to introduce Congresswoman Grace Meng for remarks. Congresswoman Meng currently represents New York's 6th Congressional District in the United States House of Representatives. She is a member of the powerful House Appropriations Committee. She is also a continued leader in our community, and most recently in this Congress introduced H.R. 151 to address the anti-Asian hate inflicted upon the Asian American community, continuing the work that she and her colleagues started in the 116th Congress introducing H.R. 908. Among her leadership roles, she serves as first vice chair of CAPAC. We are thrilled to have her join us today, so please join me in welcoming Congresswoman Grace Meng.
Thank you so much, Madeline. Good afternoon. I'm Congresswoman Grace Meng from Queens, New York. It's such a pleasure to be part of APEC's Health Summit this year. Of course, I want to begin by thanking Madeline and APECS, your board, your staff, your volunteers, your sponsors, for your commitment to addressing the health disparities facing our AAPI community, and to all the panelists for being willing to share your expertise. This pandemic has really impacted the lives of each and every one of us. It exacerbated existing inequalities and caused immeasurable heartache for those who suffered loss of a loved one or loss of employment. As you may know, last spring, New York, my home state, was the epicenter of this COVID-19 public health emergency, and my district in Queens was the epicenter of the epicenter. We witnessed it all firsthand before the rest of the nation. Surges of patients flooding our hospitals on the brink with limited staff and PPE, our elderly population succumbing to COVID-19 in nursing homes, small businesses in financial distress, families at risk of homelessness, and essential workers risking their lives and their families' lives to keep our cities running. And we've come a long way since spring of 2020, but we still have a long way to go in terms of recovery. Just yesterday, Congress passed and the president signing into law the transformative $2 trillion COVID-19 relief package, the American Rescue Plan. This will literally help get vaccine shots in people's arms, get our kids safely back to schools, get people the financial relief they deserve so that they don't have to compromise the health and safety of their families. We have indeed come a very long way since a year ago. And as vaccines continue to be administered across the nation, it's imperative that we have accurate information in order to address health disparities and racial inequities among vulnerable population, especially communities of color. For AAPIs, the model minority myth is one of the major barriers to health because it paints our community as a monolith. This misconception masks the glaring health and socioeconomic disparities that are experienced by the 48 sub-ethnicities within our community. It is absolutely critical that our government collects and disaggregates data on administered vaccines to ensure that our vaccination plan includes our most vulnerable populations and our communities of color. Last month, I led over 70 of my congressional colleagues in urging HHS to collect and make public a national demographic breakdown of administered COVID-19 vaccines. Additionally, many communities of color rely on office-based clinicians and primary care providers as their most trusted source when seeking medical advice or attention. I'm leading a letter to the White House coordinator of the COVID-19 response, urging him to include office-based clinicians, including primary care physicians, into the COVID-19 vaccine administration plan as soon as possible. This is critical to ensure we are maximizing every available resource to distribute vaccines to hard-to-reach communities, especially among communities of color. Just like our commitment to social distancing and mask wearing over this past year, we have to remain committed to ensuring equitable vaccine distribution for all Americans. Thank you again for having me, and I hope you all remain safe and well.
Thank you, Congresswoman Meng, for your continued leadership. It is now my privilege to introduce the moderator of our panel, Vicki Nguyen, an NBC News investigative and consumer correspondent based in New York. She reports for all platforms of NBC News, including NBC Nightly News with Lester Holt, Today, NBCnews.com, and MSNBC. Prior to joining NBC News in 2019, Nguyen was a reporter at NBC Bay Area station KNTV, where her investigative reporting has led to multiple state and federal investigations into changes in national policies. Vicki has received numerous awards for her reporting, including a National Emmy, the Gerald Loeb Award for Business and Financial Journalism, and the DuPont Columbia Award for Broadcast Journalism. If you didn't catch her special last night on NBC News Now addressing the racism virus, you can catch it at nbcnews.com/now. Vicki, I turn it over to you.
Thank you so much, Madeline. It is my pleasure to be here with APAICS today. And thank you also for letting people know about our special last night. I really do hope you all will tune in because it really is about our community, for our community. Let's get to our distinguished panelists. Let me give you an introduction of who all is going to be speaking today. First, we've got Dr. Diane Paloma. She's the CEO and chairperson for the King Lunalilo Trust and Home. Dr. Nia Aitaoto. She's Associate Professor of Nutrition and Integrative Physiology at the University of Utah. Dr. Sherry Daniels, Executive Director at Papa Ola Lokahi. Tony Lee, Director of Public Policy at Amerisource Bergen. And Dr. Winston Wong, Chair and Acting CEO of the National Council on Pacific Islander Physicians. So we have an esteemed panel today to answer a lot of your questions. Make sure you are entering those. We're going to have time at the end of this discussion to get to your questions. But let's go ahead and talk about, how we're going to address the group. We want to clarify. We're going to be using the acronyms AA for Asian American, as well as NHPI for Native Hawaiians and Pacific Islanders, so that we can be sure to represent all of our communities. So Tony, the first question is for you. The Biden administration is saying that they aim to have enough vaccines by May for all of the American people who want one. As a representative from Amerisource Bergen, talk about what this means for you from the perspective of a vaccine distributor. How are you going to meet this timeline, May?
Yes, thank you, Vicki. First, Amerisource Bergen is very pleased to help sponsor this conference, this inaugural health summit, and I'm pleased to represent and speak to some of these issues. So I'm glad you did clarify that the Biden administration announced that they believe that manufacturers will have enough vaccines to vaccine the entire country by the end of May. But that's just the first step. The second step is to get it distributed to the sites of care, and then it has to be administered to enough people who want to accept the vaccine. And that's a true issue. The population of the US is about 330 million, and Dr. Fauci and the administration has said that about 70 to 85% of those people need to be vaccinated to achieve sufficient amounts of herd immunity. And that translates to about 230 to 280 million people. And you contrast that with the amount of people who were vaccinated for flu vaccine in 2019 to 2020 season. That was only about 165 million. So there's a gap. So we are going to reach the inflection point where there is not enough people wanting to get the vaccine, and we still need them to be vaccinated for everyone to be safe. So it's not just individual immunity, it's everyone getting inoculated, enough people getting inoculated. So I'd like you to keep that in mind as you consider all our public policy, government issues, and the issues we're talking about, how our communities can get involved to help not only the specific A and HPI communities, but the country as a whole. So first, in terms of Amerisource Bergen, we're a very large drug distribution company. We've been supportive of distribution efforts of the vaccines to date, and we applaud the launch of the federal pharmacy program early. It was going to be in stage 2, and now it's in phase 1. And so that will help get the vaccines distributed. However, for a while now, we have been advocating for greater use of the entire traditional pharmaceutical distribution chain, because right now only about a third of it is being used to send out the vaccinations. So the entire manufacturing sector and the government and think tanks were used to very successfully, get some vaccines going, and there will be future ones, hopefully. So why can't that be also be in the distribution area? So right now the situation is bifurcated. There's 2 areas. Pfizer is distributing their ultra cold storage vaccination through utilizing FedEx and UPS. And then for the rest of the vaccines, McKesson, another distributor, has an exclusive contract to distribute those vaccines. So currently Moderna and Johnson & Johnson, and we suspect AstraZeneca will be the next step. So they distribute to whomever the jurisdiction tells them to. So that's usually the state or the locality. So they go to health departments, hospitals, pharmacies. Independent of that, pharmacies had been distributing to long-term care centers. But now, with the pharmacy federal program, there's 21 national pharmacies partners and independent pharmacy networks that are being utilized. And AmerisourceBergen is actually we're just involved in part of that. We primarily help administer to our independent pharmacy customers through the Good Neighbor Pharmacy Network. So we don't touch the product. We help administrate those contracts, which will eventually get the vaccines to those pharmacies. We currently only distribute to 5 states in Guam, but that is increasing. And hopefully that will increase as time goes on. So I hope that provides a little bit of context.
Yeah, it definitely does. Interesting numbers too. Only 165 million people got the flu shot. And if we want to get herd immunity, you said 230 to 280 million people would have to be vaccinated. So masks may be with us and social distancing for a while. A follow-up question quickly, what are you all doing at AmerisourceBergen to make sure that the vaccines get to the most vulnerable populations? Do you have a say in that? You said you're in 5 states in Guam.
Sure, that's currently through the federal pharmacy program, but we keep advocating. We have been working, for example, for advocating for administration reimbursement. I think it's about $18 for the first dose and $25 for the second dose. So that helps, obviously, the administrators of the dosages to stay in the program. We advocate strongly for access to our independent pharmacies. Our Good Neighbor pharmacies are there. I think another panel had a statistic where 90% of people are within 5 miles of a pharmacy. And regardless of whether that's exactly correct, it shows that these pharmacies and pharmacists know their neighbors and they're very involved. And so they're very much the first line of healthcare, and we want to help them also. So we work all the time. We work internally. We work with our industry groups, and there are a lot of challenges that we work. That is our expertise in distribution. And so in dealing with the Biden administration and the CDC and working with our stakeholders and industry contacts, we work on different issues because, of course, we want all the minorities, including AA and HPIs. But there are certain issues, such as the issue of internet connectivity, which is all well and good. But there are some people, of course, who just need to use the phone because they don't have it. But the flip side of that is if they are calling the pharmacies, then the pharmacies are overloaded and they're not able to administer the vaccines and at a high rate. So it's a flip side. It's a real problem. There are real issues to get the data out there, but it's not so simple. There's some complexities there. So our pharmacies have issues of knowing when the shipment will come in. There's been some priority changes. Obviously, you can say what you will about the previous administration, but I think everyone has to say it's certainly been much more coordinated. And also within that now, it's not just that the Biden administration is saying, okay, from now on, let's really help and prioritize administering to teachers, but they're saying make that a priority of what you have right now. So it's a constant shifting, and I can tell you in our government affairs department, we work with our industry people, we work internally. And, if there was a monthly meeting, it's now weekly. If there was weekly, it's now daily or, twice a week. So we are working quite hard. So in conclusion, there's other areas for example, when we choose how to distribute to the states that we are currently assigned to as an administration partner, we look at the social vulnerability index of 15 factors by the CDC, which includes language and income and racial disparities, all sorts of reasonable factors. So that does encompass a lot of the areas where the very stratified, in terms of social and economic status, Asian NH and PI community is. So we're helping to help everyone, and we are very conscious of the situation of the ANHPI community. Thank you.
Hey, Tony, thank you for that. Dr. Wong, on that note, how do you ensure that members of the Asian American community receive the vaccine? Are you seeing that there's any vaccine hesitancy, or is this just more a matter of access and getting through on the internet or getting through on the phone to make an actual appointment?
Well, I always think it's difficult to make generalizations because, for one thing, of course, the Asian American, Native Hawaiian, Pacific Islander category is a really wide diaspora. And as we would say anything about, for example, a catchment of Korean Americans in LA, it'd be pretty different to make that same conclusion for Native Hawaiians in the rural part of that state. But having said that, I think to the point that our previous speaker made is to make community access points really universally available. So when we see kind of concepts where the LA Dodger stadiums opened up for Angelenos, I think we also have to question the fact that there's a Los Angeles Chinatown that is literally half a mile away from the Dodger Stadium, but those people are not necessarily going to go into Dodger Stadium because they don't feel comfortable even traversing that area. They don't necessarily have the assurances that there's going to be people who speak the language who are culturally adept at providing the vaccine. At the clinic that I'm associated with, Asian Health Services in Oakland, they had a vaccine clinic a week or two ago, and they administered 1,000 vaccines over the course of the day. And the reason why that was done so effectively, it was because it was at a community senior center in the middle of Oakland Chinatown. And I think that would be the one thing I would recommend, is as we look at the all the unique features of our Asian American, Native Hawaiian, Pacific Islander communities, we have to place the access points that are really very much neighborhood focused, culturally adept, and linguistically accessible. That's probably the universal rule that we have to play.
That there is making sure that there are as few barriers as possible. Dr. Paloma, Dr. Aitaoto, and Dr. Daniels, what can we do to help hard to reach Native Hawaiian and Pacific Islander populations with vaccine access? As Dr. Wong spoke about, even within this community, there are many different subcultures and different reactions to the vaccine and different levels of enthusiasm, frankly, for going to get it.
I'll let you start, Terry.
Oh, I guess it's getting punted to me. So I think for Native Hawaiians and our Native Hawaiians here in Hawaii may be a little unique to those that reside on the continent or in Alaska. So I think Dr. Wong's point about community-driven, community-focused really needs to be at the forefront. And again, when we are bringing together multiple communities geographically, especially here in Hawaii, where we're talking about different island communities, how do we have conversations with our Department of Health, who is the distributor, lack of a better word, of these vaccines, and how do we make sure that the messaging for our community is consistent, working with not only the other partners, the other PI communities and the communities at large, but how do we stay community focused? And that's been the overall challenge, not only in the vaccination distribution, but even during this past year with COVID, because unfortunately, I think sometimes we utilize systems that are already in place, that has already been, moving along for decades or generations. And now we're at a pivot point of how do we do things different that really moves the limelight on community engagement in a way that's very community focused, not just by words, by actions. And that, I believe, has been a continued challenge in a lot of our AA-NHPI communities, specifically in our NH community, where we've had to really adjust to what that relationships look like. Because I think for community, we got it. People know how communities are, but it's then turning around and engaging those others to come along with us as a community and work alongside of us.
Dr. Paloma, you want to jump in on that?
I'll just add that I think it's a lot of persistence on our part for us in the Native Hawaiian Pacific Islander community. We are the advocates. So those of us working in nonprofits, those of us working in community health clinics, we utilize what we call the coconut wireless. We use a lot of integrated relationships with each other to be able to communicate to each other, so that when we know that there's a vaccine clinic on the other side of the island, we're calling our grandmas, we're calling our aunties and uncles on that side of the island to say, hey, auntie, make sure you go to that clinic on the other side. It's not in my community, but it's in yours. And really just being able to share resources in Hawaii, small island community. And we want to make sure that we look out for others in the best way possible. And to do that, you have to have that relationship. You have to have what we call pilina, or this connection and tie to each other, in order to be able to create that persistence. And hey, you know, like, hey, auntie, hey, grandma, it's important for you to get vaccinated. Let me help you. How can I help you? In my work, I'm in a nursing care home. We're a hybrid nursing care home, SNF, as well as assisted living facility. And really, most of the appointments that were available for vaccines were made through an online scheduling process by the hospital. And so many of our kupuna, or our elders, were unable to navigate that system. And so, of course, us working in healthcare, we are the advocates for them, and we're the ones who help connect them to that. And I know Nia, Dr. Aita Oto knows this well. I'll go ahead and let her comment as well on that.
Yes. So for us, we all know COVID-19 is not new, but access to vaccine is actually, it's not new. You know, access to COVID-19 is new, but access is not new. And then if you're brave enough to enter into a very uncomfortable conversation, and it's around trust, right? We've been talking about communities' trust of the vaccine, but we also feel that the system do not trust us to take control of our own health. You know, so when COVID-19 hit, way back in April, we actually got all of healthcare professionals, and then all of people in academia for Pacific communities, all our community leaders. Back in April, we conducted an assessment to assess what our community wants. We also assess our resources. We actually talked to community health centers, healthcare provider, look at their capacity to provide testing, treatment, and actually vaccine. We actually even tracing. We were talking about testing, tracing, and all that way back in April, before everybody started talking about it, and yet nobody's listening to us. So, and then all of these regional groups, they all got together and developed a response plan that go all the way to recovery. In April, we were thinking about recovery, and we covered everything in between. And with that, now we're talking about vaccine. We're still using all of the assessment results from back then. We're also using a lot of lessons learned even before COVID-19 hit, right? Everybody talking about, let's go back to normal. Normal was not good for us. We don't want to go back to normal. We want to go back to something much better than normal. So when we're talking about vaccine, we're looking at like, think about the access issue to the vaccine. Have trust in our community. We know how to do things. And this whole paternalistic relationship with the way that we care for our health needs to stop. You know, so I feel that having that trust will enable us to do, because we know how to advocate for vaccine. We actually have communities, Pacific Island community, actually go directly to the health center, go directly to the state, and ask them, let's just give us a number of vaccine. Is it 400? We'll get 400. 300 people. We'll get our people together and ready for the vaccine. All of that happened. Actually, we recruit more than 400, 436, and in all of that, all our community do that. And the point is, all of those assessments, all of those things that were done in April, May, and June of last year, zero funding from the federal government, was all volunteer. All the AAPI organization that received funding on behalf of AA and HPI, we didn't see any of that. We all volunteered. When we talk about these 300 people that are in the response team for the Native and Pacific, are all volunteer. We do it after we do our regular jobs. So let's consider that. Even the data, earlier on we were talking about data. Well, we do all of that assessment where all the universities are waiting for their IRB approval. By the time they publish that data, it's the end of the pandemic, So what we did is we would collect the data, use that to advocate for our vaccine, to look for funding and all of that kind of stuff. The point here is that we've been doing this for a long time. COVID-19, it's not, the struggle under COVID-19 is not new, but, and I feel like what's going on is Pacific Islander are finding their voice and we're all mobilizing. Thank you.
Thank you, Dr. Aitayoto. I like the coconut wireless. That's a fun visual. Can you speak, Dr. Daniels, to this idea of how you address the challenges of caretaker facilities, getting the vaccinations to vulnerable populations, but also the elderly?
So, I think that, and I know Diane can probably talk more to that, but when we look at partnerships, one of the things that are really unique in our communities is that we know how to come together. And I always say we're kind of this communal. We're very like pack animals almost, but we're very communal. It's not individualistic. And so when we look at how we distribute the vaccine or engage communities, we're coming together as partners. And so I think what's happening is really playing to our strength as a community. And so, it's very similar to what Diane said, is how do we get these partners in the queue to get vaccinated? How do we engage each other to know what's happening around us? Here in Hawaii, we have a Native Hawaiian Pacific Islander Hawaii COVID response team, and it's our 3R team. It was about response, recovery, and resilience. And it's not about, this is just during COVID. We recognize that this is a platform for us to continue and to model what it means to come together. So, and I think Diane can talk more around specifically the Kupuna Health Services.
Yeah. And actually, I shared a little bit earlier how most of the appointments that were initially available for the vaccine for those aged 75 and over were all done through an online registration and appointment system. And so me running a care home, I can't get 42 different appointments for 42 different individuals. And I'm looking at Tony Lee just because there were so many networks and contacts with us with the pharmaceutical companies. The pharmaceutical companies made a priority list through the Hawaii Emergency Management Association in order to be able to kind of prioritize these skilled nursing facilities, the assisted living facilities. So we were actually considered tier 1 in our state for the vaccination. I'm happy to say 100% of all of my assisted living residents have been vaccinated. We already had our second shot. In fact, we've kind of made it into a little bit of a party, but really that couldn't have happened without the advocacy of having this network, of having this open communication through our the 3R team and through other national networks to be able to look at how do we get the most vulnerable, how do we get them? These aren't ones like us that can get in a car, make an appointment, and get down to a mass vaccination clinic. Really, we needed to rely on other sources for them to come to our kupuna, our elders. So happy to say we're 100%. And in the meantime, we also got our staff vaccinated too, knowing that we are a closed, a closed system with limited visits, limited outside external vendors. And really to be able to make that happen takes a lot of advocacy and a lot of communication. But because we had those networks already established, it made it so much more easier for an institution like mine to be able to tap into that. Nia, Dr. Aitayoto, I also know You've also advocated heavily for your elders in other communities. I don't know if you wanted to share something more about that too.
Yes, yes. And for us, is that we have to, and Tony, the work that you're doing, having, pharmacy have access to, that's important work, because, that community access, you have to go through the Department of Health and the county, and then all of you, we have to advocate on our level, right? And that takes time, time that we don't have, especially, at that point. And once that advocacy, then we have to find spaces for us to, to administer the vaccine. We have to find even registration. That's another big thing, right? Because in some states, they don't allow community-based organization to register for their client. You have to register on your own and that kind of thing. We don't control the registration. So even if we have, for example, 200 spot, it's not guaranteed it's 200 Pacific Islander, because whoever is going to go into the registration and get in front of the line, they will be able to register and come, right? So all of those barriers, all of those things need to get looked at. And then all of there's so many other issues, around, transportation to the vaccination clinic and all of that kind of thing. Even, at one point we were looking for folks to administer, right? We even have to call out, having a list of NHPI healthcare providers, so we have a list available at a certain time. So all of those details are in our plans, so we just realized, we have to have a clinical community-based organization, vaccination clinic, policy and procedure, what I mean? All of that kind of work. So we, overnight, we have to get together and figure all of that out. So all of the, all of the details is actually overwhelming sometimes, but I feel like our community deserves, the best, right? So, and we're doing it. We look at other communities, a lot of them are not even going that far, right? Even planning all the way up to who's going to be the greeter to greet that elderly person in their language, in their culture, right? That's how detailed we're going through this. That will help with the trust issue later on after the pandemic.
And I think, Dr. Itoto, when you talked about, we don't want to go back to the way it was before. The way it was before was bad. So hopefully, and it does sound like this has really helped to solidify what you do want to keep moving forward and what you want to leave behind. And I'm hearing so much about the community coming together and having autonomy. I think that's been important. And, I can tell you, when my parents went to go get their first shot in New York, my dad almost didn't get it. Here's a senior over 65, has his ID and all the proof of residency for New York. And at the point of service, and he's there with my mom, who has her New York license. My dad still has his California license because it hasn't expired yet. And also he's not driving here in New York City. But even with all of those things, the person was like, oh, you don't live in New York City, or we can't, you have to have a New York City ID. And that's actually not the rules. So people have to know the rules, but people also have to use common sense. Here's a senior citizen in front of you with an appointment, ready to get vaccinated. You have to be able to have the freedom to do it, to do what you know is the right thing to do. So hopefully you all are being empowered, because clearly you have the right knowledge. Tony, let me bring you back into this. You shared some stats earlier, but it just, I think, helps to frame the discussion a little bit. What are some things that address how COVID-19 is being addressed in the AA and HPI community, in terms of anything that you've come across that really stood out to you? And I'm really fascinated by the numbers of people who want to get it versus those who don't. How do you overcome that hurdle if people are feeling like, no, I'm not sure, maybe this isn't safe, maybe this isn't good?
Yeah, I mean, the way to answer that is to say, there is a dearth of data. When I was doing some research, I saw that the CDC and the Kaiser Family Foundation cited them, saying that the rate of immunization, of COVID immunization among Asian Americans, and I think it was just Asian Americans, was pretty much similar to that of whites, and which is, of course, much higher than African Americans and Hispanics. But of course, as we know, with everything, the Asian American community is very stratified in terms of socioeconomic status. With the language issues, Representative Meng pointed out there's 48 subgroups. I certainly learned something today. I didn't realize it was that high. So those are real issues. So I'm sure if it's the same as whites, that means that affluent, to just put it simply, African Asian Americans are getting vaccinated, and those who aren't are really not, to equal it out and have a a stable rate like that. So, and in fact, actually a report that was dated yesterday, I think it just came out today, by the CDC, was the first to look at, I believe it's Native Hawaiian and Pacific Islanders under the age of 25. And they found that the rate of COVID among that category is twice as high as the national average. So that's really what we're talking about is and then I'll add another thing. To be fair, it is difficult. If there's 48 language groups, it can't just be a government solution. Hope, it'd be great if it could, but we as advocates for the Asian American and Native Hawaiian and Pacific Islander community have to do our part also. But the illustration is the National Association of Chain Drugstores, so they're the corporate entities, the big ones, the CVS's and Rite Aid, Walgreens. They, in their own group, they issued a report looking at racial disparities in COVID vaccination. And they broke it down pretty sophisticatedly in some Texas, and I believe Idaho, I might be getting that wrong, but anyways, in at least 2 or 3 states. But I did notice that they only looked at the Black and Hispanic communities. Mm-hmm. And so it's not a criticism. It's a way to point out that an organization that did such a thorough job just didn't have the resources to go further down. So it is a challenge. And we do need more data along with just simply getting everyone vaccinated as fast as we can.
Who should be collecting that data? Because I agree with you. Early on, it was the same thing. We were seeing, the death rates for Black communities or Hispanic communities. And I was wondering, what's the death rate for the Asian American community? And there's information is nowhere to be found. And I'm curious, you all are a smart group of people who are working in this space. And clearly, you can't rely on the federal government to collect data across all of these micro groups. But then are we measuring it? Who's going to be in charge of doing that?
So Vicki, maybe I can chime in here. I was on another webinar yesterday, and I made the comment that when the first 25,000 deaths occurred in the United States, there were no reported Asian American, Native Hawaiian, Pacific Islander deaths. And everybody knows that was a total mythology. The fact is, there were plenty, hundreds, thousands of Asian Americans, Native Hawaiians, Pacific Islanders who died in the first 25,000 cohort. But it is a travesty of justice to say that they didn't count because no one counted them. So actually, my organization and National Council of Asian Pacific Islander Physicians, we went to task at the state level, seeing if there was any data that captured in terms of reportable cases, whether it was fatality rates or admission rates, that gave us some clues in terms of the breakdown for the different groups. And we literally had to go hand count across states. And then slowly, some of the states, Washington State, Hawaii, a little bit in California, relying on counties basically to take up the effort, started counting. And then you start really seeing the disparities that Tony just mentioned. For example, in Arkansas, Northwest Arkansas, 4 counties, the #1 death group is among Marshallese. No one would have seen that unless it was broken down that way. So I think now we have a CDC leadership, NIH leadership, DHHS leadership that's leaning the right way. But it behooves all of us on this call, this panel, to continue to agitate that we need data that is captured at the local level and then also aggregated at the state level and then aggregated at the national level. It is so important for not just the large Asian groups, but groups like the Bangladeshi up in New York State and New Jersey. They need to be counted because we know that there's probably a very high disproportionate death rate among that population.
Agitate, I like that word.
If I can chime in a little bit. So here in Hawaii, we kind of, I think, are unique in that we actually, our Department of Health, through some very strong advocacy and encouragement, started to disaggregate further from the NHPI pot. I think many states use they fall back on that, well, OMB 15 just requires us to collect this at minimum. So we're doing what we have to, but I think we're saying you need to do more. But here in Hawaii, when we started recognizing the impacts that it was having in particular to our Pacific Islander populations, the department started to disaggregate Native Hawaiians out of the NHPI bucket. What makes it very much more challenging here in Hawaii is the multi races people come with. You know, people are not coming with just one race ethnicity. They're coming with sometimes 4 or 5. And so the Department of Health looked at pulling out Native Hawaiian. If there was any indication of Native Hawaiian of the choices, they put them into a separate bucket. So we really truly got disaggregated data. But I think the bigger piece too is that what happens post-COVID? That was only done with COVID positive cases. That's what we're looking at. So the question that many communities asking is, what happens after COVID is done? How can we continue this trajectory of collecting data that's really about communities? And I think many communities want to know, even though they're small, even though it maybe doesn't look well for them, they want to know, because if we don't really have a true baseline of how we need to improve, or maybe things are really great, and how do we sustain that? I think that's the other messaging that we got to look at, is that it's not so much hesitancy about getting vaccinated or getting vaccinated. It's about, at least for Native Hawaiians, it's about looking, observing, watching, taking what we call kilo, right? We're taking the time to really determine the value that has for ourselves and for our ohana, for our families. So, you know, we're starting to really change the wording as well. It's not hesitancy. It's not that we're hesitant. I think our community is very clear what choice they're going to make. What we're finding is people want more information to make a better decision for themselves and their families. And so I would like to see us move away from hesitancy to more of thoughtful, decision. It's about self-determination and, choice at the end of the day.
Mm-hmm. People want to feel like they're making an informed choice and that they have the right information to do so. What about mental health? That has been such an important issue of health that has been highly affected. We talk about the physical health, people going to the hospital, people experiencing all of the terrible things that come with COVID-19, many people recovering, but the mental health toll that this has taken over the past year, the social isolation, especially for our elderly. Can you speak to some of the things that you're working with, or some of the successes that you found in helping people who are struggling to cope?
If I can jump in just a minute for a moment, absolutely. We're in an industry in elder care that already deals with many, many mental health issues of isolation, abandonment, and possible issues of depression. And while we, of course, put a lot of their physical needs first, medication, food, nutrition, etc., often mental health issues get pushed to the back burner, in a sense. And just before COVID-19 hit, we were actually working with clinical psychologists on site, on board. So actually that they were on our facility and our site for about 6 weeks just prior to COVID. And I will say that the 6 weeks just had a tremendous effect on the emotional affect of my elders and my kupuna, so that when COVID hit, they already had the relationship established with that clinical psychologist who was on site. And so while we replaced the actual face-to-face visits with Zoom calls, and I will say Zoom calls don't ever really replace a face-to-face visit, it did help to transition our elders to a mode of still being comfortable to talk to somebody. And so I think that's why it's so important for us to have these relationships. And when we look at our AANHPI communities, right, we are a community. And so we look at how do these relationships play important roles in either facilitating healing, which is what we try and do in our care home, but also to facilitate advocacy and access, right, for COVID vaccinations, or for data, or for information on what is the best strategy for COVID protocols and policies. And I will say that the flip side of that also is not just looking at our patients or looking at our residents, it's looking at our staff. Our staff had a tremendous year of pretty much, I come from a very sports-oriented family. We're blocking, right? We're the offensive line. We're blocking, but we're not just blocking, 3 downs at a time. We have been blocking since last March, and so the fatigue that comes with keeping COVID out of our care home is real. And I'd say that the mental health of our caregivers, our physicians, our nurses, our social workers, our staff is being felt. And I think now that we've come to this point where there are vaccines, I can see some of them letting down their guard a little bit more than clinically I think they should. But also, how do we manage and maintain the mental health of our staff and our employees and all of us here on this call? I mean, we are true advocates. This is our day-to-day job and our lives, but to be able to let down our guard in any way, or to let down the guard on behalf of our communities, is almost a non-existent choice for us. We have to be there to block continuously, and we will be there even as a vaccine rolls out, to continue to do that. And so, those two facets, right? Not just the patients, the elderly, the vulnerable populations that we serve, but also the communities that are serving. I think it's really, really important to be able to look at their mental health and well-being. It allows all of us here on this call to continue the work that we do. And so, yeah, I'll let someone else share. I just wanted to put that out there in terms of mental health. I think we all need a mental health day ourselves.
So,
yeah, I'd like to.
Go ahead, Dr. Wong. Take care of the caretakers.
Well, yeah, I think that's such an important message. And, we have the pernicious effects of caretakers really being frontally assaulted, verbally, physically, in the context of xenophobia and the racism against Asian Americans. So, I'm actually writing about this a little bit with regards to how the frontline providers, for example, nurses of Filipino descent, who are really one of the heroes and champions of this whole pandemic, they themselves having the highest rate of mortality among healthcare workers in California. They, at the same time, confront individuals on the street or even in the hospital who question whether they can be treated by this person because of the nature of what they look like, or that they're being spat upon, in their daily life. This is really a mental health issue that is directly related to the consequences of anti-Asian hate, xenophobia, and for us to acknowledge that the COVID-19 pandemic is basically exposed the historic raw nerve that exists with regards to how Asian Americans, Native Hawaiians, and Pacific Islanders are perceived in this country. So I think you mentioned at the very beginning, Vicky, about the minority myth, or I think the Congresswoman did. We need to say that myth was constructed not by our community, and in fact, it's a myth that needs to be exposed entirely for the damage it does and for the consequences of mental health for all of our communities. This is really getting to be a dangerous situation. So the only other thing I'd mention is COVID-19. There's some suggestion that the virus itself has impact on their neurologic system, the central nervous system, that also invites kind of moving into severe clinical depression. So that's an area of potential ongoing and future research as well.
Where are you going to put that paper, Dr. Wong, with those stats? That's really fascinating about the Filipino nurses, actually. I'd like to see if we can pitch a story to highlight that that's what's happening. I did not know that.
Yes, you can see the San Francisco Chronicle ran an article about 2 days ago about the experience of a Filipino nurse in San Francisco who was questioned by a patient if she would be safe being taken care of by this nurse. In addition, there's the Philippine Nurses Association of America that has put out a statement about the incidents relative to their profession.
Thank you. Does anyone else want to weigh in on the mental health aspect of this before we move to the next question? Okay, let me just,
Vicky, Yeah, I'll just say that, AmerisourceBergen has been addressing issues of racial inequality and disparities, and we have employee resource groups for African Americans and Asian Americans and Hispanics and whatnot. But I just noticed this morning on our internal page they did put out a statement by the leader of the Asian American advocacy group, and they did cry the Asian American violence. So, I think the whole point of that really is not about my company. It's in all sorts of areas of society. I've been involved in talks that I otherwise wouldn't have over the last year. So I think that's important to note, is that at least it's having some impact on all of us talking about these issues.
Well, our theme this Health Summit is to rise up to the challenges that we are facing after a year under the pandemic. So to wrap up this part of the discussion, this is for all of the panelists. How do you think AA and HPI communities are rising up to the challenge of recovery and resilience from vaccinations during COVID-19? Dr. Aitaota, let's start with you.
Okay. So for our community, I think we're banding together. I think for the longest time, we all work in different states, different locations and all that kind of stuff. But I think this gave us the opportunity to come together and then move forward. It also gave us a voice to really call out on a lot of the injustices, right? So, just for this, this group here, it's time for us to reflect, and not just Native Hawaiian Pacific Island, for all of us to reflect, right? So if your organization serve API, what does that mean, right? Who's the P in there? What are you doing for them? Who's representing us and all that. So that's how we want to move forward. We also want to finally getting our voice out there that says, for NHPI, we're not just some caricature that we used to justify policy agenda and funding and all of that kind of stuff. We're real human beings that we have, the capacity to do our own work, and then so all of us in moving forward, that's why I said earlier that we want to get back to not normal. You know what I mean? So it's a path that COVID-19 gave us the opportunity to pave that path. But I think that we have a long way to go. But this is such a safe and wonderful space to be in, to be honest about those feelings. That's a gift in itself. Right. So thank you. Before I leave, I want to thank, APAICS for putting this together. Thank you, Vicky, for facilitating, and all the panelists. Y'all were wonderful.
Oh, we're not letting you go just yet. We still have audience questions. It's been great, and we appreciate to have a free flow of thoughts and ideas and exchanging these, best practices. So let me go to you, Dr. Paloma.
So, and just to add on to Dr. Aitaoto's comments, absolutely. I think the way that we move forward and the way that we've been able to elevate the community's voice in this whole pandemic and in the pandemic response is to be able to engage the community, right? I think when I was training and in healthcare, clinics were very focused on only a certain select portion of the community that they served. And now we see them collaborating, sharing data, sharing information, and really being able to interconnect with other communities. And like Dr. Aitaota said, this is not regional anymore. This is a national issue. Looking at other work that I do, the Asian Pacific Islander American Health Forum also is looking at ways on how to amplify and communicate better with those communities. How do we allocate all of resources to what we learned, the 48 different ethnicities and races? And really, I think, I will say, because I am part Native Hawaiian, but I'm also part Asian American, that Native Hawaiians and us, we're an island state. We are surrounded by, 25,000 miles of water. And we've really had to learn how to take care of ourselves in a way, and be able to collaborate with those that even may think a little bit different than us. And it's that connection. Again, I'm going back to that word pilina, the relationships that we cultivate with each other that is so critical for us to move forward. And now we have relationships with national partners, with pharmaceutical companies, with providers and caregivers, relationships with people who are producing the data that is so, so critical for us to be able to allow people to engage with our organizations, and then allow us as organizations and institutions to be able to engage back with the communities. So yeah, I'll just leave it at there and let somebody else answer.
Dr. Wang, you want to talk about that, the resiliency aspect of it and lessons learned so far from this pandemic experience?
Yeah, sure. Thank you. You know, I was also writing something else. It's the irony of it is Asian Americans, Native Hawaiians, Pacific Islanders make up a significant portion of the healthcare workforce. And, you know, I was saying kind of in a glib way, you know, if you put together Grey's Anatomy, you have to have the cast member be the Asian American doctor, you know, Sandra Oh or something like that. But the point being that we as healthcare professionals need to weigh in for all of us in terms of what communities we come from and our dedication and commitment towards caring for the American public. You can't separate these two elements. And as we come to you as a healthcare provider, whether it's a nurse, pharmacist, physician, nurse's aide, we come to you with everything we have. And that is not only a commitment to serve you best, but also the lived experience we have as immigrants, as Native Hawaiians, as refugees, as people who have made a great journey to try to accomplish the American dream. And when our issues are not identified, it is maybe our fault for not forcing where we need to go. And for other communities to recognize that we are not an invisible group of people that just do our work. We represent communities. And when we bring our work as healthcare professionals forward, we bring that part of us too.
Dr. Daniels, pick up on that. We are not an invisible group of people, and quite frankly, we contribute a whole heck of a lot.
I think we do. You know, similar to what Dr. Wong said, we may not be the physician you see, but we may be the housekeeper that's cleaning up that room. We're the security guard that's keeping that facility safe. So our community is quite broad in what we bring to the table. You know, I do also want to talk about where do we go from here? You know, as AA and HPIs, we see health as a whole. Health isn't just about I go to the doctor and I get medicine, or I'm not feeling good. Health is about how healthy is the food that I eat or where it's grown. Diane touched upon here in Hawaii our system, right? We have a lot of our products brought in. What does that mean around food security or product security? You know, it's about health in where you live, the land you have. And as Hawaiians and as Indigenous people, you know, our birthplace is significant to us. So when we have, you know, close to half of our Native Hawaiians that reside out of our state, what does that mean in terms of their health, in terms of connection to culture, which is part of a social determinants? So I think when we look at our communities, we need to really recognize how is health viewed to our communities. That's moving forward. But also, you know, we tend to throw out words like allies and partners, and we need to collaborate. But what does that mean? Because what it means to me as what I'm going to call a little n, meaning, and this is, I guess, a FYI, the federal government identifies Native Hawaiians in terms of blood quantum to access land as 50%. So I get the great, I guess, responsibility of being a little n, of being 50% or more. That's burden. So I think when we look at allyship and partnership, what does that mean to me? What does that mean to Diane or to others on this call or you who are listening in? I think we really need to take some ownership around what we expect as an ally and what we can give as an ally. And I think that's really important because it's okay to be honest. It's okay to tell us or our communities, I can't, or I'm not sure I can really do what you're hoping I can do. because that's more honest and that's more real. And I think that is much more appreciated from our community versus having very false expectations. And I think that that holds true to as we hold people to task in those spaces and how people behave. When we look at the government and how any government, whether it's federal, whether it's states, how they track us, how they use us, how they use the data that's collected about us. Are you including us in that conversation? And where does it go with this? So this is a really large undertaking that we hopefully all sign up to push forward. But I think we have to also hold to task some of those folks in positions of power. Because again, for us to have our voice beyond COVID, systems are going to have to change. And right now, the concern that I have looking at what's happening is, I don't know if the system is going to change. I think they made adjustments during this period, but is those adjustments going to be sustained afterwards? And is there real legitimate, authentic wanting for us to succeed? I think that's really important. Is we all want to succeed. Our communities want to succeed. We're very resilient. But that's really hard to continue when there's barriers that don't allow that to happen.
Mm-hmm. Well, on that note, Tony, there's an audience question asking, what is AmerisourceBergen's post-pandemic plan to address the most vulnerable and rural communities and their pathway to recovery? Is there anything specific post-pandemic that you can speak to?
Sure. I'm not sure what the questioner meant exactly by post-pandemic, but one thing that we do is we distribute actually exclusively the COVID-19 therapy. So we're very excited about that, and we think that's very valuable, certainly. So, it's like everything else. Everyone is reevaluating things. We're looking at our structures and trying to make sure everything is fine. But the bottom line is right now, the distribution network exists, and we distribute pharmaceuticals and inoculations to all sites of care. And we'd like that to continue and to be used for the COVID-19 vaccine.
Dr. Aita-Otto, question from the audience. Are there barriers to educating the local, rural AA and HPI communities on best practices to deliver information about vaccine access, and how do we overcome those challenges? So I know you've talked about that there are barriers. So what's the best way to get that information into the hands of the people so they can make the decisions that they need to for their health?
So here in Hawaii and nationally, there's websites, there's toolkits that's been established in language materials, which is very important. And even in some really smaller communities where maybe language access is limited. So those are available. There are, like Nia talked about, the national response. Here in Hawaii, we have a webpage that has a lot of in-language materials and that we're sharing with our community providers that are in communities. And so really working together around that and looking what's being developed everywhere else and making sure we can share that with others as well. And it's a multi-pronged approach. We know people may not have access to the internet. We do newspapers, both in ethnic medias, we're doing social media. So we recognize for our elderly population, maybe it's their grandkids that have the Facebook, the Instagram, the Snapchats, the TikToks. So really utilizing multiple threads of engagement, really still printing out brochures because some communities still have workers going door to door. So it's you have to really engage the village to help get those messaging across.
Okay, well, as we wrap up this panel, let me start with you, Dr. Aita-Otto. Are there any final thoughts that any of the panelists have before we wrap things up?
Yeah, and I think, deep down into the value our lives, AA, NH, and NPI, you know what I mean? We feel like we're not being counted when we're alive. We're not being counted when we die. When will we be counted? So, this value, the idea of valuing our lives and for us in this space, everyone that is working with AA, NH, NPI, continue to advocate to pay attention to details, have that intention, a lot of the work needs some intention confidentiality, and then willing to work outside of your comfort zone, right? You know, a lot of people are very uncomfortable working around our spaces, you know, and then we're asking them to be uncomfortable. It sometimes is good to be uncomfortable because that's when you learn. So again, this is my second goodbye. Thank you all for having me, and for APAICS for hosting this space.
You've been terrific. Everyone has. Any other final thoughts before I turn it back to Madeline?
Yeah, sure, Vicki. I think one thing is that we're in the middle of the pandemic. We certainly have not reached the end of, we haven't reached herd immunity, but I want to say this, that we're in an acute phase of the pandemic, and the convalescent phase of the pandemic is likely to be protracted. I think in terms of not only as clinical manifestations in which we see people with long haul COVID-19 symptoms, but also in terms of the economic and social impact. So we actually have to project outwards, not just through 2021, but probably through 2025 relative to the specific aspects of COVID-19 in terms of the overall impact on our communities, mental health and other issues included. The other aspect, which was mentioned by the Congresswoman, is that if we have America's relief program, we have to capitalize on those investments to the point that we need to build a public health system and a social care system and a safety net system that meets the needs of our communities in the long term. Because as someone else said, this is not necessarily going to be the last pandemic. In fact, there's even some projections that maybe we'll see a second wave, with the different variants of COVID-19. So we actually have to use the opportunity here to plan out in terms of using those resources to build the foundation for a better system of care.
Yeah.
So Vicki, is this the wrap up now? Or? Yeah. Okay, well, so if I could, I know I've talked a lot, so if you indulge me, that I realized I did not recall and did not speak to our work, our foundation, working with access to all populations, and work with the Boys and Girls Club of America and some other organizations working in communities. And then if I could just add a few things. First, again, our industry is working hard, and there are challenges like all this data collection. It makes it harder to actually rapidly put out the vaccines, but it's just one of those things. It's needed, but it makes it tough. So some of these things are not easily solved, is my point there. But I mostly want to thank, all of the essential workers and the healthcare workers, especially. It's just tremendous. So we work hard, but we are so lucky that we have people who are doing that, and we're grateful for that. Another point I wanted to make is that, in terms of what we're all saying about speaking out and saying who we are and that we have a voice. Well, it's like the term Asian American. If you just say Asian, it doesn't match, because if you see a light-skinned person, you don't call the person European. You don't call a dark person African or Jamaican. So it's a little bit of language, because Hispanic works pretty well, but there's no proper term for Asian Americans, let alone NHNPI. But it's not only language. What it really boils down to, and it's seen in the violence against the health workers, who you would think they would say that's good. It's treating people of our descent as not American. And that's what it boils down to. And that's all we're saying is let's be Americans. Let's be united in just being able to recognize our differences and our diversity, but let's have some basic decency about all of that. And if I could make a final point, I once was on a Hill visit with a pharmacist, and that pharmacist said that he was dealing with a patient who, didn't stop taking an antibiotic because it had been 1 or 2 days and it wasn't working because she didn't wait long enough. And he said, well, it's a red and blue pill. How do you put it in your mouth? And Martha said, well, I put it in red in first. And he said, oh, you got to reverse it. That's what's happening. And the whole point there is, we saw another amazing example in a previous panel by someone who took a relative who had a stroke, and they actually, they said they broke the back view mirror to cut the person thinking that the loss of blood would be good. That's a cultural issue. So, there are some differences, but we don't have to treat this all as being mysterious and that things are so different. It's just, we are all here as an accident of birth, and we just have to make the effort to get to know each other and to work it out. And so, that big cultural difference is tough, but, like the woman who just didn't want to take the drug and was skeptical, we all have to work kindly and in some cases stridently, in certain cases like violence, to work on that. So and I'm glad we're in healthcare, because it's really good that in this situation we're working to make that all better, because it's so important for everybody. So thank you.
Any final thoughts, Dr. Paloma or Dr. Daniels?
Just, Tony just reiterated, right? It starts with that individual personal touch. It's not one organization, one type of caregiver, or one institution that's going to help us get to the next level and past this, right? Dr. Wong reminded us this is not going to be, it's not the first, it's not the last. But I would encourage everybody out there who works in their industries, whether it be the video technicians or whatever it is that you do, to start making those connections with people in your community. We found through our meal delivery program a number of issues relating to people who we deliver the meal to, and we would never known those things without making that initial question or ask or check in, like just saying like, hey, how are you doing? Is there anything I can do? And I think that's just the start for individuals, that lead to families, that lead to communities, that lead to this global village that we have, on really being able to look at caring. And for us in healthcare, right, that's part of the word. It's caring for each other, which is the fundamental root of all of our cultures. So just wanted to highlight that. And I think I have friends here for life. I call Nia and Sherry my sisters, because we've worked together for so long. And that's that network that we've built years ago that enables all of us to be able to work for the good, for the population, for the people. Thanks.
Thank you so much for leaving us on that very positive note. And let me turn it back over to APAICS President and CEO, Madeline Milka, for our final remarks.
Thank you for moderating such a dynamic discussion, Vicki. I would like to thank all of the moderators for creating an environment to learn and to share information. And thank you, audience, for attending this day-long event, even during the technical difficulties. We hope it brought attention to the important health issues that are impacting the Asian American, Native Hawaiian, and Pacific Islander community. And of course, much thanks to all of the panelists who provided such incredible insight in sharing their expertise. Before we end, I'd like to thank our event partners who have helped to make this event possible: Novo Nordisk, Amgen, American Cancer Society Cancer Network, AmerisourceBergen, and Grail. In addition, I'd like to recognize the APAICS team and event consultants for putting this inaugural health summit together. I believe they deserve a round of applause. And I invite you to participate at our upcoming Legislative Leadership Summit from May 10th to May 13th, where we will discuss policy issues that are important to the Asian American, Native Hawaiian, and Pacific Islander community in honor of Asian Pacific American Heritage Month. Registration begins on March 24th, and we hope that you will be able to join us. Stay tuned for more details, and feel free to check out our other APAICS programming by visiting www.apaics.org. Thank you for taking the time to participate. I look forward to seeing you the next time.